So, when there is deficiency of thyroxine or at hormones, so by negative feedback mechanism, the anterior pituitary will start secreting TSH, thyroid stimulating hormone. Is that right? This thyroid stimulating hormone in turn stimulates the thyroid gland to, it causes thyroxine. So there is deficiency of thyroxine. So the cells start, it causes the proliferation of these thyroid epithelial cells. And there is a proliferation of these cells which results in ultimately the goiter to compensate for the deficient thyroid. And as a result, a persistent deficiency of thyroxine will result in stimulation of thyroid stimulated hormone and therefore formation of a goiter. Now what is goiter? Let me tell you, the thyroid gland is the only endocrine gland which is visible and palpable. Okay, only endocrine gland. So therefore, what I will tell you, goiter is a visible and impalpable swelling. What is it? It starts before you. Thyroid gland, if there is a swelling of the thyroid gland, it's a enlarged gland. It may be anything. It may be a goiter, it may be hyperthyroidism, or it can be malignancy, or it can be any of the autoimmune disorders or autoimmune thyroiditis, Beethoven's disease, or it can be Hashimoto's disease, it can be Raynaud's thyroiditis, or whatever it is. Anyway, so thyroid gland, when it is not secreting thyroxine, will by negative feedback result in stimulation of the thyroid gland by thyroid stimulating hormone, which is secreted by anterior pituitary, and this hormone too is under the control of thyrotropin releasing hormone from the hypothalamus. Is that clear? Now, when we are talking about thyroid gland, why it happens? It is a stage of that. Why it happens? It happens because of deficiency of basically the iodine in food. Okay? And this is common among those places where the water is running down and the iodine is getting washed off in mountains like in Latin America, in European mountains, or in mountains of India also. Is that right? Then there are other causes of thyroid swelling. Person may be taking, some medicines which are goitrogens. Person may be taking, food, vegetables of brassica family which are goitrogen. And there may be certain hormonal factors like dysharmoniogenesis. Okay? The thyroid may be enlarged when there is demand for metabolic demand during puberty. During puberty, the growing period, and during pregnancy. So, thyroid gland gets enlarged. Okay, this much of this. Now, you will come across many cases of thyroid swelling in your ward. So, history of that patient is very important. History is very important. What are you going to ask the patient? You'll ask when you see the thyroid gland. You're going to tell him it's getting worse or anything. What is the duration of this swelling? What is the onset? How did it start? Was this swelling has started increasing suddenly? The thyroid swelling, which is a pre-existing swelling, which was already present there, but suddenly it has increased in size and there is a pain now. So this can be due to either hemorrhage into the thyroid gland and it can be sudden increase in size of the swelling along with pain, and it can be due to malignancy also. You see, this rapid increase in size of the swelling, person has already get some kind of a malignancy. There are various types of malignancy which we discuss later on. Okay, so there is a cyst formation, or there is some kind of a trauma also, there will be aneurysm also, that may cause bleeding side. So you will take history of onset and duration, history of pain, history of fever with the swelling in the thyroid region. And then of course, these factors are there. Then you must ask the patient, which is very particular and pertaining to thyroid, how is your appetite? How is your appetite? Is appetite increased? A person who has got a thyroid swelling, his appetite is increasing, but he is not gaining weight. There is a suspicion that person may be having hypothyroidism. Is that clear? Or a person is gaining weight despite the fact that patient has got loss of appetite. Patient has become, you will ask the lady question, are you feeling lazy? Is there any energy? So, this you have to distinguish from hyperthyroidism with the hypothyroidism. You both can give rise to thyroid swelling, increase in thyroid swelling, and swelling in the thyroid region. Is that clear? So, besides that, you will ask the patient. The patient with hyperthyroidism, if you notice, will be an anxious person. Anxious, anxiety, he is nervous, he is irritated, he is not friendly. And when you examine, we'll discuss it later on, his hands are warm, he is sweating, he has got heat intolerance. What he has got? Heat intolerance. Even in winters he is feeling warm. Okay? And when he walks, he is walking, he will do something like this, something like this. Like these are the movements. And when he's walking, in hyperthyroidism, there is a proximal muscle myopathy. And therefore, these people have problems in getting up from the chair. And their gait, you see them, it's a rapid gait. It's just rushing to it. Whereas in hypothyroidism, the person is lazy, is lethargic, his mental process is retarded. His thought processes are slow. His patient has got a typical puffiness of the face, and patient has mask-like face without expression. Is that clear? So besides that, you have to take history of radiation to the thyroid region. In 1986, there was a nuclear accident in Ukraine, and subsequently what they found, there was increased incidence of pituitary carcinoma of thyroid in younger people. So you have to also ask history. Is there any exposure to radiation? Is there any past experience of lead? Is the patient taking any medicines and things like that? So let us proceed further. This will be about it. Then you have to come to general physical examination. General physical examination pertaining to the thyroid swelling. What is most relevant is the build of the person. The person has got, who has got tachycardia. He has got thyroid swelling. He has got exophthalmos. Exophthalmos. You have heard about exophthalmos? Exophthalmos are the prominent eye balls. Okay? And you'll see what stress actually means. So person has got exophthalmos, he is irritable, he is nervous, he is anxious, he has got sweating, he doesn't sleep well, he eats quite a lot, and he is thin-built person, stingy type of person, irritable. Okay? So pulse rate is generally high in these patients. So there is a trial rating of pulse rate. That is, it is called trial, C-R-I-L-E. This person is not right. Trial, C-R-I-L-E. Trials grade 1. In thyrotoxicosis, and there is a thyroid swelling, the pulse rate will be increased. Grade 1 means the pulse rate will be up to 90, pardon me, 90, grade 1, 90. And 90 to 110 will be grade 2, grade 2. And more than 110 is grade 3, Clinics criteria. And this pulse should be taken while the patient is sleeping or he is relaxed, or you are giving the patient is some sedative, like some kind of a tranquilizer, mild sedative like diazepam or clonazepam and things like that. Okay, the pulse rate will be high in patients of hyperthyroidism, whereas the pulse rate will be slow in hypothyroidism, whose thyroid gland is not working properly. There is a deficiency of thyroxine, so you cannot straight away blame the person has bradycardia. What is bradycardia? Bradycardia means heart rate which is less than 60. So therefore you are also to exclude other causes of bradycardia. What is that? The lumping heart block. It may be hypothyroidism or mixed edema. Patient may be taking beta blocker. Beta blocker, that means we learn the beta blocker. Patient may be taking beta blocker. Patient may have some kind of a fever like that because of typhoid fever. Is that right? And there may be some kind of other problem. So therefore, in such patients, you will see the pulse and the blood pressure as well. That physical build, the person having hypothyroidism who has got mixed edema, with clinical features called mixed edema. What is it called? Mixed edema. In hypothyroidism, person is dull in appearance, gaining weight. Whereas the hyperthyroidism, patient is intolerant to heat. He cannot tolerate heat. Even in winter he is feeling warm. Whereas in mixed edema, a person hypothyroidism is feeling cold even during thick of summers. He wants to quit. Mixed edema. So therefore, he stops. And hypothyroidism, patient has got cold intolerance. Cold intolerance. In summers also they will be taking wind carrying. In hypothyroidism, person has got cold intolerance, bradycardia, puffy face, dull state of mind, loss of appetite, and weight gain. Weight gain. So that is the feature of hypothyroidism. Thereafter, you examine the palm of the patient, they are perpetually sweating in hypothyroidism. Okay? And other features are hyperthyroidism. The person will be having this progressive, there are certain eye changes. There are certain, are you feeling all right? You have this water or that means if you are feeling more, you can take this electrolyte. I always carry it with you. In hyperthyroidism, person, the disease may progress to such a state that he has got prominent eyes. Eye won't as if they are protruding out. This is called exophthalmos. Exophthalmos. E-H-A-L-M-O-S. Exophthalmos. P-H-A-L-M-O-S. Exophthalmos. Focus. Exophthalmos. Exophthalmos are the eye signs in hyperthyroidism, which is called Graves' disease also, because hyperfunction of the thyroid gland increased secretions. Okay? It may be an autoimmune disorder also. So, anyway, we'll discuss about the investigations later. So, in exophthalmos, what happens is, besides the features which I have already told you, patient will be having hyperthyroidism. tremors like this. The person, outstretches his hands and you can feel the fine tremors. It will be fine tremors and you can see, just keep a pencil over this and you see the whole thing. The tremors will be there. Okay? I have already told you that you can see the tongue which remains inside, you can see the movements there also. But coming to the eye size, the eyeballs become prominent and certain stage the sclera is visible above the upper limbus and the lower limbus also. That means in exophthalmos, this is the eye here. So generally, with the cornea, the upper lid covers half of this portion. It's covered by the upper eyelid. But in case of exophthalmos, the upper limbus sclera and lower side also sclera is visible. Sclera is visible, which generally is not. Is that clear? But what are the other features? This condition is called, when the eyeball is white happen exophthalmos. What is the reason? What is the reason? There is a retrobulbar collection of round cell infiltration and fluid. There is accumulation of fluid in hyperthyroidism behind posterior to the eyeball, which forces eyes to become prominent and sclera is visible. Okay? This is called exophthalmos. If this process continues, again, the person will have exposure and there is possible chances of damage to the eye. The conjunctiva becomes red and inflamed. Red and inflamed. There is chemosis. There is chemosis. 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 There is a retraction of eyelids. There is conjunctival swelling. There is ultimately a person may have ophthalmoplegia. The muscles may be partly paralyzed, ophthalmoplegia, and as a result, he is more prone to ulceration and ultimately the blindness. This is called malignant ophthalmos, which is not malignancy. Malignant ophthalmos, malignant exophthalmos is complication of hyperthyroidism when sclera is visible, there is swelling of the conjunctiva, there is edema, there may be papilledema, there may be corneal ulceration, there is diplomia, there is ophthalmoplegia, and ultimately the blindness also, which is called malignant exophthalmos. Okay, now let us see, there are various tests for hyperthyroidism. What are those tests? Number one is lid retraction. What is that? Lid retraction. Lid retraction is upper sclera is visible. This is called Dalrymple sign. What is it called? Dalrymple sign. DALRYMPLE. Dalrymple sign. Lid retraction. The sclera is visible. Generally, it is not visible. You look into each other's eyes, you will find the lids partly cover the cornea above the pupil. Okay? But in exophthalmos, you can see the sclera. Okay? Then another test for us to proceed further is lid lag. What is that? Lid lag. Lid lag is there. Lid lag, this is called Wall reflex side. Wall, E-O-N, form, is pronounced as form reflex side. Lid lag. Lid lag means the upper eyelid is not keeping pace with the movement of eyeball. Okay, look. Lid lag, I will repeat again and again, because we have instructions that repeat and repeat, because some of you have not read it. So I have to repeat. And that is why I will draw your attention also by repeated one place. Lid lag, what did I say? Lid lag. Lid lag means, how do you test it? The surgeon stands on the right side of the patient, okay, and he keeps left hand on the head of the patient. Whenever you are touching the patient, I can tell you this much, touching the patient without consent, even if you are examining for the first time, you cannot do it, particularly a woman. A lady has to be in attendance. You get a point? Here, I must add here. No doctor can examine a patient without the patient's consent. And if you're going to operate on the patient, it has to be informed consent. Meaning whereby you are explaining to the patient what are you doing. You're going to operate, what are the benefits, what are the side effects, what are the complications. And if you don't get operated, this is the problem you will face. You are likely to die in case it is so. But you have to have an informed consent. So before you touch a patient, a female patient, putting a hand, male doctor putting a hand on the female's head, which amounts to an offense which in Indian law is punishable. And people have been punished for examining a female patient without a female attendant. Okay, this is called battery, a serious offense. What is it called? Battery. But every day we go to a patient, daily, can you take informed consent every day during your ward rounds? You cannot do it. So there is an understanding and politeness between doctor and the patient. A trust has to exist. Otherwise, there also the patient will say, she can say the doctor came in the morning and he put his hand on my head. So it is virtually a kind of a trust subsequently. Now, you examine lid lag, you are putting a hand on the head of the patient, left hand, and patient is asked to, look forward and bring a finger, your index finger, in front of the eyes. What are we doing? I am standing, I am the patient here. Your finger will come in front of my eyes, okay? At the level of my eyes. I'll bring a finger like that. And my left hand is over the patient, like this. Then I'll instruct the patient, look, you should start looking at the finger. So your finger should start coming down, slowly. And patient is asked to look at my finger. In a normal patient, the finger is going down. The eyelid is also falling. So look at me. So my eyelid is following the movement of the finger. But in the case of hyperthyroidism, in the case of excessive mass, there is a lid lag. That eyelid, upper eyelid, is not able to keep pace with the movement of finger, and this is called lid lag. It is lying there, and sclera is still visible. That means patient has got the feature of hyperparathyroidism. Okay, this is called lid lag test. Then comes your another test, eye test is patient with hyperthyroidism. The patient is asked to look down and then asked to frown, look at the roof. Patient is like this, he has flexed the neck and asked the patient to look at the roof. Now see me. I will ask you to look at the roof. So there is a wrinkles on my forehead. But in case of hyperthyroidism, there are absence of wrinkles. Okay? There are absence of wrinkles. Another feature I cite is a person with hyperthyroidism, he has got bad looks, staring look, no blinking. Patient doesn't blink. Generally we are blinking. We have to blink. Our eyelids are blinking. Is that right? But in case of thyrotoxicosis, there is staring look. If a person does, there are some people are in habit of blinking unnecessarily and they are got into problem. They are going to the magistrate, they are going to the teacher, and they see a few people, they generally blink, and it's considered as kind of a social bad habit. Okay? And some people have been punished also. And then staring also. You can't stare at a person. It means it's a kind of that you are not welcome and some kind of hostility is there. Alright? This is called staring, Stellback sign. You read that. Von Refe's sign, Stellback sign, Moebius sign. Then another test is the convergence test. Convergence test. What do you do? Keep the finger at the level of the eyes of the patient. Again, you put the left hand on the head of the patient. And patient is asked to look at the tip of the finger. Look at the steps. And then this is the patient here, in the eye of the patient. So you gradually bring the finger closer to the eyes at the level of the roof of the nose. Now look at me, what happens to me? See that? What happened? There is convergence of eyes. You have seen my eyes converging. But in case of thyrotoxicosis, patient fails to have convergence. That means there is involvement of muscles. Okay? There is an involvement of muscles. What are the inferior oblique or inferior rectus or something like that? Okay. So the failure of convergence is there. In case of, when you are saying this convergence test. This is called Moebius sign. M-O-E-B-I-S. Moebius sign. Moebius sign. What is this called? Moebius sign, which is failure of convergence. Now, there are certain people who have got a thyroid swelling and you have difficulty in examining the thyroid gland. So what will you do? There is a short neck, the person is obese. What did I say? Person has got a thyroid swelling. Person has got thyroid swelling and patient has got short neck and is obese also. Now thyroid is not accessible. So what you do, there is a test. You ask the patient, and lock the hands behind at the opposite extremity. Now the neck is accessible. Thyroid gland is more accessible. Is that right? This is called relaxation of the neck, and then you can examine. You get more access. Okay? Alright, you understand that a person who is obese, who has short neck, you can increase the area of accessibility to the thyroid gland by asking the patient to be slightly extend the neck and put the hands behind. Next is eye science indicators. Pemberton's sign, Pemberton's test. P-E-M-B-E-R-T-O-N'-S, Pemberton's test. Why it is done? because I have not touched yet the patient. It's just going through the test only. These are important before we proceed further. And I would like to take a next lecture also in continuation of that. If you are bad, let me know so. Pemberton's test. What did I say? Pemberton's test. P-E-M-B-E-R-T-O-N-S. Pemberton's test. A person, this is done in those patients who have got a large goiter. And part of the goiter, it may be multinodules. There are multiple nodules called multinodular goiter. What is it called? Multinodular goiter. And sometimes the intrathoracic pressure rises and one of the nodules goes into the thoracic area, to the suprasternal notch. The thyroid is extended right up to suprasternal notch and it gets into a nodule and nodules get sucked into the mediastinum, thorax, intrathoracic, become intrathoracic, and suddenly when the pressure rises, this nodule is thrown out. This is called plunging thyroid. Plunging, P-L-U-N-G-I-N-G. I am talking about the thyroid gland having multiple nodules, in which one of the nodules gets sucked into the thorax, intrathoracic, it becomes intrathoracic. Patient has a problem. It becomes a retrosternal goiter. And once this happens, what is going? There will be pressure effects. What will happen? I told you I am talking about Pemberton's test. So, what happens is the trachea will be compressed. Trachea will be compressed. Veins will be compressed of the trachea. So, the person may have respiratory distress, number one. There will be dilated veins over the neck and the chest, number two. And patient has, what patient has got? Difficulty with breathing. So, and if you percuss the sternum, that resonance is lost and it will dull because the nodule is there in the intrathoracic part of the hindsternum. Is that right? So for this we do the Pemberton's test. In Pemberton's test, what you do is you ask the patient to stand and raise both his upper limbs close to the ears for 3 minutes. For how many minutes? 3 minutes. If it is a retrosternal goiter and they mind you sometimes, that will be the only thyroid swelling. It may be an ectopic thyroid lying somewhere else. And when you are operating on thyroid, make sure that you are not removing the thyroid gland here. There is a thyroid gland, ectopic thyroid gland somewhere else also, called linear thyroid. So one has to assess the patient very carefully. Now in Pemberton's test, the patient raises both hands for how many minutes? 3 minutes. And with that, with this, your thoracic inlet is getting narrow. And when it's getting narrow, then all these problems happen. The patient will be having dilated veins on the neck and the chest. He may have sinuses, bluish discoloration. There is a puffiness of the face, and patient may have respiratory distress, and this is called Pemberton's test. Now coming back to this kind of test, I am talking about 5 signs also. There is another test, it's called Nash-Zigger's test. Nash-Zigger. Nash-Zigger. N-A-F-F. Z-I-G-E-R. Apostrophe. Nash-Zigger's test. What did I say? Nash-Zigger's test. N-A-F-F. Next onwards, next class onwards. Big I'm of writing. Nash-Zigger's test. Nash-Zigger's test. What did I say? Nash-Zigger's test. Nash-Zigger's test means that you stand behind the patient. Go behind the patient. You stand behind the patient and you extend the neck of the patient and look at this. You cannot see the eyeball. And if you go behind the patient in a normal person, if you stand behind him, you ask ask him to extend the leg and see the supraorbital region here, supraorbital margin, you will see only this part, supraorbital region. But if there is an exophthalmos, if eyeball is protruding out, you will see the eyeball also, because protruding out. This is called Navigator's test, which is positive. Okay, this is called Navigator's test. These are the eye tests you do. Thereafter, let's come to the gland proper. Now, examination. Firstly, you have to come, if a person comes to you swelling in the neck, a person is coming to you with a swelling in the neck. How will you say that this is a thyroid swelling? How can we say that this is a thyroid swelling? So, give him a glass of water and I'll give you something with that and see what happens to you. Observe my neck. What is that? You haven't seen this. Thyroid swelling moves up with deglutition. Deglutition means when you are swelling. When you are swelling something, and the swelling in front of the neck in the thyroid region, which doesn't extend beyond thyroid cartilage. Let me tell you this also. Thyroid, this is the thyroid region. Okay? Two lobes right and the left, and this is the isthmus here. There is swelling here, and I take something, your attention please. I'll bring your attention. Are you feeling, any one of you feeling sleepy? So say so, we can have a break to have one of the minutes or so. Take a deep breath. Lamba सांस. Take deep breath. Take it out. Slowly now. Anyway, these are the things we have been told. Listen to it. NCI instructions are that doctors are supposed to be artists also, to break the monotony of this long lecture. You have to sit for hours together. I'm sorry. Next time, please be with me today. So I got a chance to talk to you for once in a week. So we have been told clearly that in between you can crack some jokes, you can utter some poem or something like that. And I was surprised when one of our teachers, he had come from Oliva, he was delivering a talk. And he abandoned the talk and he started dancing with us to store our side. He is a crazy person. There's something wrong with him, he's moving his hand and feet and things like that. Then he told that I want to break your monotony. So anyway, I was talking to you about thyroid swelling moves with deglutition because the pretracheal fascia, the vascular pretracheal fascia, which is called Davies fascia, D-E-R-R-Y-S. Davies fascia is attached to pretracheal fascia, is attached to on the posterior, medial, and behind the thyroid. Okay. It in turn is attached to thyroid cartilage, larynx, and inferior constrictive muscle, which is acts in deglutition. So when somebody is moving, the inferior constrictive muscle, and the whole thing to the larynx, they move up. Okay? It moves up. And one person has got a thyroid swelling, it definitely will move. But it will not move in certain conditions where thyroid swelling always moves up during deglutition, but there are exceptions where, number one, please note it down. This deglutition test is not present when the thyroid is massive, big thyroid, huge thyroid. Just by sheer weight of it, it doesn't move, number one. Secondly, if there is malignancy of the thyroid. What are the malignancy of the thyroid? There is malignancy we tackle later on. But you should remember, when cancer has infiltrated all around and fixed the thyroid gland, you cannot expect thyroid to move up. It is being held. It's a person who is held up from all sides. He cannot move. Okay? And a few strong chaps have got it. So therefore the malignancy at thyroid, which has been fixed by malignancy, infiltration, thyroid has been moved on. And even the carotid sheet, may be involved, and you will not be able to palpate the carotid arteries. You will not be able to feel the carotid arteries. Okay, this is called Bailey sign. Okay, Bailey, there are so many names. B-E-R-R-Y, Bailey sign. Bailey sign. That you cannot, feel the carotid artery. Where do you feel the carotid artery? By the way, the carotid artery is felt at the upper border of the thyroid cartilage. See carefully. Examiner is going to ask you, please show me how you feel the carotid artery. It's very much part of your thyroid examination. Where do you feel the carotid artery? You feel the carotid artery medial to both the sternocleidomastoid muscles at the upper border of the thyroid cartilage, at the tip of the sixth transverse vertebra, which is called Chassagnès point. What is it called? Chassagnès point. C-H-A-I, right now. Chassagnès point. C-H-A-I-S-S-A-I-G-N-E. This is the tubercle of the sixth cervical vertebra, transverse process. So, it is here. Now I can feel my carotid artery. You can also feel it going, but not, press too hard. There are so many things here. Carotid sinus is also there. Beware. Okay. What is it called? Which is Chassagnès point. C-H-A-I. Repeat. C-H-A-I-S-S-A-I-G-N-E. At this particular point, you see the carotid artery, and in carcinoma of the thyroid, which is infiltrating all around, you will not feel the pulsation of carotid artery. Is that clear? Okay, let's see. One point I touched is thyroid swelling moves up with deglutition, right? What are the other swellings which move up with the deglutition? Examiner is going to ask you what are the others, and I say it is not thyroid swelling, but it's going up with the swelling. So what it could be? It could be thyroglossal cyst. It could be thyroglossal cyst. You know the foramen secret behind the still part of the tongue. There is a thyroglossal duct which extends up to the thyroid, and during development it passes through the high bone, thyroglossal duct, and you find a cystic swelling in the midline. You find it? What swelling? Cystic swelling, which is full of fluid, and it moves out of the tissue. Right? Thyroglossal cyst. Now, how to prove that this is thyroglossal cyst and not the thyroid gland? So, what you do is you do a test. What is that test? You stand on the right side of the patient and hold the cyst with the thumb end up like this, and ask him, extend the neck, and ask her to protrude the tongue. Take out the tongue. Hold the swelling. Extend the neck. Yeah, that's right. Good. And ask the patient to protrude the tongue out. So you will feel a kind of a tuck. The swelling will move up the deglutition. No doubt about it. But you feel a tuck. Okay? It's moving up. Is that right? The thyroid swelling will not move up when you protrude your tongue, but thyroglossal cyst will move up when you protrude the tongue. Is that clear? Okay. Then there is a pretracheal lymph node, prelaryngeal lymph nodes. I hope you know that the different topic altogether, lymph nodes of the neck, various group 1A, 1B, 2, 3, 4, 5, 6, 7. Anyway, that's not the point in the concentration. I am focusing on thyroglossus cells pretracheal, not retracheal, not they move up when during when the tubes are coming out. Okay, only thyroglossus cells. Otherwise, there are other lymph nodes, pretracheal laryngeal lymph nodes, which also move with deglutition. Okay, now other test for the thyroid gland. What is satisfied? Now you have to inspect the thyroid. I have not come to that stage. I am just still there in the examination. Inspection. Inspection is what you see. What you see there are visible veins over the thyroid gland. There is a swelling. Is it smooth or it is nodular or inspection? If it is a smooth swelling, we should have thyrotoxicosis. It is hyperthyroidism. Is that right? And in that case, the veins will need to be highly vascular. Becomes vascular, and you can find the visible veins in the neck. Thyroidism. Okay, number one. Secondly, patient may not have thyrotoxicosis. It is also increased in malignancy, cancer, carcinoma of the thyroid, papillary carcinoma, or anaplastic carcinoma. We get infiltration. Then you can see the visible veins. Alright. On palpation, what do you find? It may be soft, it may be smooth, it may be cystic, it may be firm, it may be hard. Consistency. In malignancy, the thyroid gland will be hard. Hard. There is a condition, Rydell's thyroiditis. Sorry. I am talking about consistency. Rydell's thyroiditis, there is a fibrosis of the thyroid gland, becomes hard, not malignancy. Okay, in hypothyroidism, thyrotoxicosis, on examination, you will find it may be slightly reddish also. There may be some kind of infection also. Now, on inspection, you will find multiple nodules. Now, palpation. You palpate the thyroid gland with the palmar surface of the fingers. On palpation, you find the consistency, no doubt about it. And you also see how are the margins. Are they ill-defined or well-defined? Is it tender or non-tender? The thyroid gland is tender in certain diseases like autoimmune thyroiditis, dequervance disease, dequervance disease. These are very relevant points. Person has got pain in thyroidism, there is a swelling, there is tenderness, and there is fever. This is thyroiditis, probably maybe autoimmune thyroiditis. Okay? Or it may be Hashimoto's disease. Have you heard about Hashimoto's disease? Hashimoto's disease. So, what happens in these cases? Thyroid peroxidase antibody will go up. It should not be more than 25. I have seen cases of thyroid peroxidase, anti-thyroid peroxidase antibodies have gone up 2000. Ultimately, the gland is not 100% land of hypothyroidism. So, palpation means you see the temperature in the back of your hand. Temperature. Is it warm or hot? Maybe thyroiditis. Is it tender? Is it painful? Right? Is it hard or firm? Or is it soft, smooth? Okay. Then of course, I've already told you. Now various tests we have to do. I think we'll finish up with the test only because it's becoming too much for you. And it's very wrong also. So there are various tests for thyroid which examiners are very keen. Please listen carefully and see carefully. There are various tests. Firstly, you have to, as I told you, you have to see that is it moving or is not bending. What you have to do is measure the thyroid gland from above downwards and right to left. Because thyroid extends from sternum and both sides and the upper border of the thyroid cartilage. Is that clear? It cannot go beyond that. It may be large. It will become very large. So you have to do the measurement, number one. Then you have to feel the surface. Are we feeling the nodules? So there are various tests which I will demonstrate to you. And what are those tests? Number one I will mention is Trials test. What did I say? One is Trials varying or pulse rate for hyperthyroidism. The other one is Trials test. Do all of you do like this? Then only you do. Show me the thumb like this. Trials test. What you do, go to the patient, stand on the right side. If you want to examine the right lobe. Now you press the thumb over the gland. See like this. You press it like this and ask him to swallow. This test is done to feel for the nodules of the thyroid gland. This is called Trials test. What is it called? Thumb over the lateral lobe. Allow the patient to swallow and feel with the thumb. This is called Trials test. Okay. Then go to the opposite side also, left side also to examine. Any asymmetry of the thyroid gland, that means you have a space on both sides. There is a 3-finger test. What is that? 3-finger test to see any nodule which might be pushing the trachea to one side or the other. You get my point? What did I say? That you have to see if the trachea is in the midline. If it is not in the midline, that means there is some kind of a nodule which you are not able to feel. And there is an asymmetry. It is turned to the left side or right side, there may be a nodule which is pushing the trachea to one side or the other. So, what you do, put your finger at the suprasternal notch and index and ring finger like this over the where at sternal head of the mastoid, sternomastoid. Okay? And then start to move finger up. If you find your finger is leading to the right and left side, that means there is some nodule somewhere, right? Okay. Then another test what you do is Lahey's test, L-A-H-E-Y. L-A-H-E-Y. Lahey's test, L-A-H-E-Y. What did I say? Lahey's test. Now if you want to examine the right side, what you have to do is, you press the thyroid gland of the left side like this. This is the patient who I am pressing the thyroid gland of the left side, and with this hand I am palpating the right-sided right lobe of the thyroid gland. In this maneuver, when I am pressing it like this, when I am pressing the thyroid gland, of the left side, the right-sided thyroid gland rotates, and the part of the thyroid gland on the right side, which is the nodule is posterior, will become posterolateral or bilateral. Then you can get it. Nodule is behind the thyroid gland. You have to press the left side, left lobe of the thyroid gland towards the right side, and you feel, press it to this side. The thyroid will rotate. This thyroid will rotate like this, and you will feel the same. And similarly, go to the left side also. You can see the bone. Okay? This is called Lahey's test. Lahey's test. I've already told you Trials test. Feel with your thumb when you press it. You get to see the nodule. So this Lahey's test is done to see the nodule, thyroid nodule, which is lying posteriorly or posterolaterally. Okay, is that clear? Now let's go to the other test. Another test for this is, we'll say, Cocker's test. K-O-C-H-E-R-S. Cocker's test. Cocker's. K-O-C-H-E-R-S. Apostrophe S. Cocker's. The thyroid is going to all of us, at least 50% of you will get as a long phase in the thyroid. Really, if you demonstrate, because your examiner, I want to give you the tips for this. I'm long on teaching this medical college. The examiner has not come prepared for examination, not at all. You as a student know much more than him. Okay? When you know much more than the guide and lead him to the side which he knows, you know the best, and he doesn't. He will be very happy. Tell him a thing that he is unlikely as read it. Tell him that. He will be stunned and will say, good, you're a good student. So therefore you are going to get these cases and you should be prepared here. And that means you already left it. Anyway, I was talking to you about Cocker's test. What I was talking to you? Cocker's. What test? Cocker's test. Cocker's test is done sometimes in the youth. I have operated youth thyroid solution. I operated a woman and touched a woman with a pepperoni carcinoma, a huge one. And the attendants were ready to see that surgery. If the attendant is ready, the patient is ready, the anesthetist is ready, what's wrong with the surgery is already explain the consequences to the patient that you can have recurrent lung paralysis. But you should not deny the patient the right to surgery if you can do it, but complications are always there. I was talking to you about Cocker's test. Now you press the thyroid gland with your thumb and two fingers, index finger and the middle finger. Push it posteriorly. Push it posteriorly. So what will happen? You are pressing the thyroid gland over the trachea. Over the trachea. And patient, in case he gets strident, you have to press in the trachea and he has got strident, and voice is there, or airway obstruction. So that is this test is called. What is this test called? Cocker's. You know what has happened? What has happened when the thyroid is lying there for a long time in the trachea? What happens? The poor chap is like a person over which you have given a lot of weight at the back. Okay? And so he has collapsed. He has collapsed. For the sheer weight. So thyroid is pressing over the tracheal rings which are degenerated. That holds the integrity of the trachea. And so far as the thyroid is there, the trachea has not collapsed, he is breathing because trachea is the wall of the trachea now. Thyroid is the wall of the trachea, and because tracheal rings are given way, degenerated. And the moment you do thyroidectomy, you have no thyroid, the trachea will collapse. Once it collapses, patient will be, you have to do the urgent tracheostomy. What do you have to do? Urgent tracheostomy, you have to make an artificial opening, tracheostomy, opening in the trachea. This is called tracheomalacia. What is it called? Tracheomalacia. T-R-A-C-H-E-O. Malacia. M-A-L-A-C-I-A. What is it called? Because of pressure effects of the thyroid gland. People have committed mistakes. It happens in our country. You can't do anything. But our public is very much awakened as compared to others. They'll immediately go to the court. And otherwise, something happens to the patient. They break the window of the nursing home, the hospital. Very, very aggressive. We are very aggressive people. We are aggressive people in certain situations, very short-hearted, and we are very weak, like a cat to pour water, where we should be aggressive and not aggressive. Okay? So therefore, tracheomalacia is one of the complications of large thyroid, which has destroyed the tracheal ring. Hence, the trachea will collapse after removing thyroid gland. Okay, now these are the tests, and thereafter what you do is to make a plain access and examining the patient, and you do the indirect variegoscopy also. Is that all right? This is all about the thyroid. Now let us see what investigation. I'm not going to say details of investigations, but there are few investigations which should do. What are those investigations? There is a thyroid panel. Basic, most active part of thyroid hormones is T3. You already know the physiology, how the iodine gets trapped in food and converted to toxin, okay, which is attached to the sub-3 T3, T4, which is most important for diagnosis. Otherwise, it gets attached to albumin, pre-albumin, and the globulin, thyroglobulin. So, we have to see the test. What we do is number 1 is T3, T4, TSH. T3, T4, TSH. TSH will be increased where there is deficiency of T3 and T4, because this is a negative feedback to the pituitary and pituitary. It is a demand, it is a cry, do something. The pituitary is telling you, do something, uncontrolled in the body. Do something about it. I'm stuck. My car is standing. I want control. I want to go run around, do something. So TSH level will be increased in hypothyroidism. But in hyperthyroidism, T3, T4 hormones, they are in excessive amount or much more than the normal values. So TSH will be increased. So you have to do T3, T4, TSH, and do not forget. We have seen a number of cases where the T3, T4, TSH is normal. But person with hypothyroidism, how to do it? So these are the patients. They have got clinical features of hypothyroidism. Flaky, not maintaining, not doing well. You have to do anti-thyroid peroxidase antibodies test also, and these may be elevated, and ultimately the state will lead to hypothyroidism, right? T3, T4, TSH is effectively appear to be normal. We go from one level to the normal. Do the TPO, anti-thyroid peroxidase antibodies, and thyroid anti-thyroid stimulating antibodies tests, and so many. But where is the thyrotoxicosis? These values will be increased, right? And hyperthyroidism, there are more of CNS and cardiovascular effects also. Cardiovascular, tachycardia, hypertension may be there. Patient may have atrial fibrillation and is thought to be some kind of a rhythm disorder. But whereas not thyrotoxicosis, a thyrotoxicosis patient will refer to you rhythm disorders. What are the rhythm disorders? Patient have already told you he's got tachycardia, and he will have collapsing pulse. What kind? Water hammer pulse, collapsing pulse. Have you heard about it? You will better read it. Hutchinson's medicine, clinical methods of Hutchinson. I hope you are aware. There's a master street. HUTCHI. Hutchinson's clinical methods. So there will be collapsing pulse, and patient may have atrial fibrillation, and ultimately, patient has got hyperthyroidism, he needs some cardiac intervention, radio frequency ablation, and pacemaker and things like that. Okay? You have to examine the patient follow. Next investigation, what you should do is the ultrasound. Ultrasound is a very good investigation. It can measure the nodule even up to 2 mm. What did I say? That you subject the patient to ultrasound, and it can measure thyroid nodule even up to the 2 mm size, swelling. And it will also tell you whether it is a cystic thyroid, it's a cystic thyroid, a solitary thyroid cyst, it is a thyroid cyst, or it is a nodular thyroid. It is a single nodule, solitary nodule. Listen to be careful. I am touching a very important thing. The ultrasound will tell you the number of nodules, the cyst, which can be a simple cyst or it can be a complex cyst. Complex cyst का मतलब क्या होता है? They are both solid and liquid elements in it. What did I say? Complex thyroid cyst means it has both liquid and solid elements in it. Solitary thyroid will not tell you this cancer. No, it will tell you it is there, but it can't tell you that it is the correct medical thing. You get my point? So we do ultrasound to see how many nodules where. It can tell you the nodules which are lying in depth also. Ultrasound. Is that right? It can tell you, yes, this is a multinodular organ, it is alright. And then after that, once it is done, after the ultrasound, you can do FNAC, not before the ultrasound. FNAC is done subsequent to the ultrasound. You put a needle, 22 base needle, the sensitivity is very high. Sensitivity is very high. In some of the centers, they will be able to tell you it is a benign tumor, it is a cold nodule. I am not talking to you in the classes we are taking. If I get an opportunity to take your theory classes, it may be cold nodule. Cold nodule, you understand? Which has not taken up the radioisotope scanning. That is also one of the investigations now. FNAC will tell you what is the type of cell, okay? Whether it's a nodular, whether it is a papillary carcinoma. But the problem comes with the follicular carcinoma. FNAC cannot tell you that whether it is follicular adenoma or follicular carcinoma. In follicular carcinoma, there is capsular invasion. You have to do something else for it. You may do the throughput biopsy or whatever it is. Okay? I am talking to you ultrasound guided FNAC with 22 base needle. I hope you know how to do the FNAC. Okay, the syringe of the plunger is put inside under the ultrasound guidance. And you withdraw a little bit and do multiple push and pulls and not suck it. And take it out and spread on the slide and then it's fixed to the appropriate way. This is a 5-needle aspiration cytology. What is it called? 5-needle aspiration cytology. 20 days needle, sensitivity and specificity is quite good. But it cannot distinguish between follicular adenoma and follicular carcinoma. So you have to do a regular scan before that. And then what are the other investigations? The CT scan. CT scan is a very good investigation. It will tell you the size, shape, extent, any infiltration, everything it will tell you. Is that right? And old investigations, we used to see EMR, and things like that, they are gone now. So that's all what I want to talk to you. How was the lecture? Please give me your feedback. Was it okay? Right? Next time, please ask your mistake. I'll continue with the paradigm.